You are recording.
Well, I'd also like to extend my welcome to all of you for coming here. As John told you, I'm a surgeon, primarily a GI and sarcoma surgeon, and so that makes me, in many ways, optimally positioned to take care of GI stromal tumors. As John probably also told you, he and I have been involved in some important clinical trials, and I know that he's described some of the importance of that to you in the last talk. And what I'll be reviewing today includes the results of an important clinical trial that looked at adjuvant treatment, that is, treatment following surgery for patients with localized gastrointestinal stromal tumors. So with that background, what I'll review today is basically outlined here. We'll spend a little bit of time, not much, on background because all of you have done a lot of research. You probably know as much or arguably more than John and I do about GIST. We'll then look at something that I feel is very important for all of us, for the patients who have localized disease, and that is the risk stratification approach that we use at the moment to classify patients in terms of their quantifiable risk for recurrence after surgery. This is important in helping patients to understand prognosis and also in helping us to work with patients in making decisions regarding adjuvant treatment. And then we'll look at some of the issues regarding the management of patients with primary disease. And what I mean by that are the subset of patients, perhaps 50%, that present with localized GIST that has not, on the basis of imaging studies, has not spread to other anatomic sites. Some of the background information I think is known to you. Perhaps the most important points that have been made undoubtedly already today include the fact that prior to the advent of these newer medications, such as imatinib, we were talking about a disease for which survival was probably best measured in months. And as you know now, we're looking at a disease that has been completely revolutionized over a 10-year period of time with survival durations that are now really calibrated in years, even decades. And as many of you know, we have patients that have been on imatinib for more than 10 years with this disease. It gives you an insight into the phenomenal changes that have occurred over less than a decade as a result of our understanding of science and the ability for us to develop targeted treatments that you know very much about already. Let's see here. One point that's perhaps under-discussed, I think, is this concept of microgist, and this will give you an idea of how common this disease, this condition really is. Microgysts are defined as gysts that are smaller than 1 centimeter in size, and what we know about this is that they're actually remarkably common. If we were to estimate that there might be, let's say for discussion purposes, 100 people here today, then 30 of us in the room right now have microgysts in our stomach. We know this on the basis of work done in Asia and in Europe, where patients who were undergoing surgical removal of their stomach had the specimen, that is the entire stomach, carefully reviewed millimeter by millimeter. And when that was done, as you can see here, they found microgysts, in this case less than 5 millimeters in size, present in 1/3 of stomachs, and here nearly 1/4 of stomachs in this report from Germany. So it's on that basis that we believe that the frequency of these small gysts in the general population is enormous. It may be as large as 1/3 of the entire population has microgysts, yet we understand that the incidence, and this is why we have this in bold here, the incidence of what we would call clinically significant, clinically relevant gysts is just 15 per million per year. So there are obviously some factors that we don't fully understand that we can only learn through the type of work that John is doing in his lab that will help us to understand what is it that causes such a small numerator to develop out of such a large denominator. Now, I want to spend a little bit of time on this table. It's unfortunately a little bit busy, but it's the approach that we and others are using for risk stratification. And what we're looking at here are outcome data and the quantified risk for recurrence for a large group of patients, indeed over 1,000 patients with GIST who underwent surgery, had their tumor carefully analyzed and confirmed as GIST, and then underwent long-term follow-up, largely in the pre-imatinib era, And the recurrence rates are then quantified. And what you see here is that the parameters that are used to do this include the mitotic index, and I think this is probably something that John may have explained before, but it's a pathologist looking under a microscope and counting the number of cells that she or he sees dividing under the microscope, and doing that 50 times to get an average. Then we use tumor size, and you can see the size criteria that have been used here with sizes ranging from 2, 5, and 10 centimeters. And then we use anatomic site, and the recurrence rates are stratified by gastric, duodenum, which is the first portion of the small intestine, small bowel, and the lower part of the GI tract, the rectum. Now, if we look at this in a slightly different way, we can break it out, and if we were to use a financial term here, into tranches, into risk categories, just like these mortgage-backed security people do. And so this is what we could define here as the low-risk tranche. These are patients who have a mitotic index consistently less than 5 mitotic figures per high-powered field. And you can see the numbers that we should look at, and we'll use stomach as an example. Look first of all at the patients who have small GISTs. This includes the microGIST, less than 2 centimeters in size, with a low mitotic rate. Look at their risk for recurrence. It's defined here as 0. Now, what that really means, and of course there's nothing in life or medicine that's 0 or 100%, but what this means is that this condition, including the microGISTs, could be considered to be almost benign. And indeed, if we look at the survival of patients with these small GISTs and we plot it against the survival of the general population of the same age, they overlap, suggesting to us that these patients have obviously an excellent prognosis. Even if we look at these larger tumors, even a tumor, say, as high as 4.5 centimeters in size with a low mitotic rate, that patient has a less than 2% risk for recurrence of their disease. Even if we get into the even larger range, say a patient who had a 9.5 centimeter tumor that would be in this range with a low mitotic rate, that patient with a gastric 9.5 centimeter GIST has a less than 4% risk for disease recurrence. Look at the importance of mitotic rate, though. If this 9.5 centimeter patient that we would quantify in this category as having a 3.6% risk for recurrence, if that patient had instead had a high mitotic rate of greater than 5 mitotic figures per 50 high-power field, you see the risk for recurrence is 55%. So we're talking about a huge quantifiable difference on the basis of these microscopic observations. So this is the higher risk tranche. Here, this would not be rated AAA by any rating agency, and we can see the importance of mitotic rate, and you can see how this increases as tumor size increases for the patients who have a high mitotic count, 16, 55, and as high as 86% for patients who have a very large, greater than 10 centimeter GIST arising from the stomach with greater than 5 mitotic figures per high power field. This is the group that we looked at before. This would be rated certainly AAA by all rating agencies because this is the group that has a 0% relapse risk. Now, if we were to look at this group from the standpoint of does this group of patients need adjuvant imatinib treatment? Do they need Gleevec after surgery? Absolutely not. They have a 0% risk for disease recurrence. This is a group we looked at earlier. This is also a AAA group, the group that has the low mitotic index and a gastric anatomic site. And you can see that these numbers in relative terms are small. When we change mitotic rates, as we looked at before, these numbers increase dramatically, again showing you the impact of tumor size and mitotic rate combined with anatomic site. So the way that we feel that this table is optimally used is after surgery when we sit with patients and we look at their pathology report